We are live now, Doctor.
So very good evening to all of you and a warm welcome to the image and video competition conducted by the Vitro-Retinal Society of India. And this particular team of image and video competition is headed by Dr. Naresh Babu from Arvind Eye Hospital, Madurai. And he's helped in the entire gamut of collection of images and, labeling them as well as getting the votes for the various interesting images submitted by various members. He is helped in the team by Dr. Sangeet Mittal and by Dr. Chitranjan Mishra. And every month we are getting excellent images from various ophthalmologists across our country. And it's extremely interesting to see the creative minds behind these images. So I will just request Dr. Naresh Babu to conduct today's session.
Thank you, Dr. Manisha, and welcome all. So this is another session of Felicitation, which we are doing once in 3 months for all the winners. And as I have been telling, actually, it's a wonderful competition. So I kindly request all the members, non-members, postgraduates to send their images so that we'll have a very good collection of this images competition. So with that, I just will hand over the mic to Dr. Chitranjan, so who is doing a fantastic job as far as this competition is concerned. So he does almost A to Z of everything. Over to you, Chitranjan.
Thank you, Manisha Madam and Naresh Sir. Before I announce all the winners' names, I have a small request, rather some instructions regarding the presentation, because of late we are getting many images which are not as per the instruction and we have to work a little hard. That's okay, but still it will be better if the people who are submitting just follow simple rule. We need images in either PNG or TIFF or JPEG format, anything, one image and one description with a title and a short description. So what is happening of late, people are combining with a PDF they are sending, or they are sending just the image and not the description. So we have to remind them separately in the email. So my request to all the people, you please keep submitting images as many as you want, and thank you all for submitting the images, but just follow this thing, one image file and one description file, that's all. So with that, we will move ahead to the winners. The January 2023 image and video competition, the third prize goes to Saurabh Damodaran. So Dr. Saurabh is a retina consultant in Arvind Eye Hospital, Madurai, and a very good junior, innovative guy, and very nice retina doctor. And this is the image for which he has got the third award, that is a double RVO. So as Dr. Saurabh could not make his presence in this presentation, I will be speaking on his behalf. So what he has mentioned, a 50-year guy presented with this kind of clinical presentation where we can see both superior temporal quadrant and inferior temporal quadrant. There are retinal vein occlusion pictures, and the patient had cystoid macular edema as well, and he was underwent multiple intravitreal anti-VEGF injections, and till the final visit, the patient was doing well. So this is a little different presentation. My question to any of the panel, how frequent we get this, and prognosis wise, is there any difference if we compare with superior temporal or isolated inferior temporal retinal vein occlusion? Any of the
I think we have seen sequential, but simultaneous occlusion very rare, but this looks more like a vasculitis, right, Chitranjan?
Okay, he has not told about the vasculitis part. What he has told that regarding the etiology, he has not mentioned much.
Yeah, looks more like a vasculitis in this case.
Yes, sir. And prognosis wise, do they differ in comparison to other RVO where we get like the number of anti-VEGF injections or progression to neovascularization of the iris or
I don't know whether we can really answer the question, Chittaranjan, because it is rare.
yes, sir.
As Naresh has put it, sequential we have seen
Yes, sir.
patient developing superior temporal vein occlusion and after a few weeks to months developing the inferior vein occlusion.
Okay.
So that we have seen, but this is simultaneous is rare. So, but obviously being both involvement, you can expect all the features to be more severe, and they may require more number of injections. And unlike in a case of a BRVO, you hardly ever get iris neovascularization. But this being both superior and major veins, the chances of NVI may be there, but I don't know whether there is any literature on this. I don't really know. So others also can chip in their views. Yes.
Chitan, just a technical issue. Dr. Raja has messaged that there is no audio in the YouTube.
Yes. So, Mrs. Manjula, if you could just get it checked.
Manjula madam, please check it because yes.
I'll just give her a call.
We'll check, doctor.
Is the audio working on YouTube?
Yes, doctor. Yes, doctor, it's working.
If you could please give a call to Dr. Raja and check out.
Okay, doctor. I don't have his number.
I will just pass it on to you.
Actually, YouTube has got audio. I'm just checking. It's fine.
Okay, fair enough, Dr. Naresh. Thank you.
It's fine.
Is the audio working on YouTube?
Yes.
So okay then. So congratulations to Dr. Saurabh, and he wins the third prize, and he has already received 2,000. Just to mention that this time felicitation we are doing, all the winners have already received their prize money. So this is one thing different. Thanks to the team Numeratic and team BRSI for the kind coordination. Congratulations, Saurabh, again. Then the second winner, Dr. Ruchik Patel. Dr. Ruchik Patel. So Dr. Ruchik Patel is a VR consultant in Himmat Nagar and Ahmedabad, Bhagyodaya Hospital. So this is the award-winning image, a retinal crescent. This is the description what he has sent. May I request Dr. Ruchik to please describe the image. Dr. Ruchik.
Yes, thank you, Dr. Chittaranjan and VRSI. The image is of swap source OCT of left eye of a diabetic patient who presented with sudden loss of vision since 3 days. On examination, we found multi-layered retinal hemorrhages. Swap source OCT showed vitreous hemorrhage as well as multi-layered prehyaloid as well as intraretinal hemorrhages. Along with that, there was a lumen-like structure temporal to fovea, which was surrounded 3 sides by the hemorrhage, nasal, superior, inferior. This appearance looks like crescent in the retina.
So thank you, Dr. Ruchik. The message that we take, rather we know always that multi-layer in RAM, retinal artery macroaneurysm, we can have hemorrhage in all the layers. All the layers, but this kind of crescent kind of picture, and to find it out and send it to VRSA also need something creative mind like this. So thank you again. And any comments on this from our panel?
Yeah, just 2 questions. One is the site seems to be very unusual. And second thing, how this was managed by laser, direct or indirect laser, how it was managed?
No, sir. It was patient was taken into the theater. Patient has undergone a vitrectomy with focal laser and gas tamponade.
But why vitrectomy for this case?
Sir, because the patient was the vision of the patient was a counting finger. the macroaneurysm was not able, we were not able to laser the macroaneurysm. Even we have done FFA, but the leak was not visible on angiography. So we had to take the patient in OR.
Okay, but I feel it's a bit aggressive because if you do the laser, either direct or indirect, mostly indirect, usually the hemorrhage completely disappears. Fine. Yeah.
Okay.
Yeah.
So another comment, Dr. Rishik, that it's a very interesting image, but I would also agree with Dr. Naresh that here probably you have a very thick subfoveal blood there. And probably
Yes,
this patient would have required an injection with TPA gas. And many of these macroaneurysms, they just, auto
Involute
block
or auto thrombolize by itself.
auto-thrombolize, right? So because you do have the blood over the macroaneurysm as well. So I would agree with Dr. Naresh that probably you could have got away without doing a vitrectomy in this patient.
Okay.
I have a little difference of opinion here because if you see the OCT, there is a thick pre-retinal component there.
Yes.
If you look at the OCT, in front of the retina, there is a thick layer of blood. I would have probably called this a mountain over a crescent or something like that. But a very good picture. My only apprehension was laser would have been difficult here because of the layer of blood. So I don't know whether laser would have been possible without removing that layer of blood that is there on the top of the macroaneurysm. How do you penetrate up to that macroaneurysm in the presence of so much of blood, which is going to absorb your laser?
Actually, what I was saying was that many of these just auto-thrombolize, so it may not even need a laser. Actually.
Correct. Yeah, that part I agree. Most of the times I have hardly treated the macroaneurysms, needed to treat them by focal laser. Because once they bleed, I think that kind of thrombosis occurs and, they probably close off. But a good picture and a good imagination to imagine the crescent. Dr. Rishik, yes, good image. Sir. Thank you.
So thank you all panel, and what we come to the conclusion, picture is very nice. All credit goes to Dr. Rishik definitely. And regarding the management, we heard about auto thrombolysis and laser and surgery. So we have to customize, and it depends on the surgeon's discretion, what I believe. So with that, we will go to the next image. That is responsive. So again, Rusik has already received 3,000 rupees and certificate. So congratulations, Dr. Rusik. Then the first winner, Dr. Surabhi Gupta. So Dr. Surabhi is a long-term VR fellow in Dr. Shroff's Eye Hospital, New Delhi. And this is the award-winning image, the eye siren, a case of VHL syndrome. If you can observe last episode also, we saw this group of, like from this Gurukul, I can tell, their montage is very good. You can see, we should also give credit to the montaging of the images. We can see in the era of these wide field images, very good image and the eye siren. And may I request Dr. Surabhi to please explain about this image.
Thank you.
Is there? Yes.
I'm here. So, good evening, everyone. Thank you for the opportunity. And this was a case of a 25-year-old young male who presented to our OPD with chief complaints of diminution of vision in the right eye. His visual acuity at presentation was 6/12 N8 in the right eye and 6/6 N6 in the left eye. On dilated fundus examination, we can see there is presence of mild disc hyperemia with presence of these oranges nodular lesions present in the mid-periphery with associated tortuous feeder vessels, which are suggestive of angiomas. There's also presence of a thin epiretinal membrane on the macula, which is causing traction with some amount of exudation in the right eye. Similarly, in the left eye, we can see presence of multiple half to 1 disc diameter size of these nodular oranges lesions with associated feeder vessels in the mid-periphery. suggestive of angioma. This patient was undertaken for investigations, and on PET CT, we could see multiple cystic lesions in the pancreas, in the seminal vesicle, and also cystic lesions with septations were noted in the pancreas, which were suggestive of a malignant etiology. On the MRI brain, a small cystic lesion was noted anterior to the cerebellar vermis, and on the basis of the clinical picture and the investigation, the diagnosis of VHL was made. And this patient subsequently underwent photocoagulation to these angiomas in both the eye and has recently been taken up for the right eye vitrectomy with epiretinal membrane removal. This patient is under regular follow-up and is doing well.
Okay, thank you, Dr. Surbi. Just I have a question regarding the title of this image, the eye siren. Can you explain about this title? Any relevance?
I titled the name as eye siren because these patients are very young and they tend to present to the ophthalmologist without any systemic involvement in the prior nature. So I named it as eye siren because presence of these multiple angiomas is a siren and is an alarming situation for us, and we should definitely undergo all the systemic investigation for these patients, and apt and early diagnosis will help us in better management of these patients.
Good. Nicely put the title, because siren actually it is related to the Greek mythology, where you get a kind of ominous sign, something related to one imaginary creature of half a bird, half a female kind of thing. So that is related to Greek mythology. So you have combined both mythology and ominous sign. And also your image tells us that in these kind of situations, we should raise our antenna to search systemically. Like unfortunately, this patient was having malignancy and other things. So nice image. Any comments or compliments from our panel?
Yeah, just two questions, Chitrajan. One is, what was the family history? Because VHL runs in families.
Yes, sir. So there was no as such positive family history of VHL in this patient. However, there was a family history of death in uncle because of cancer, but the nature was not known.
And second thing is, was there any pheochromocytoma in this patient and whether it was investigated for? Because
yes, sir, it was thoroughly investigated, but there was no pheocytochroma in this patient.
Because usually in the complete VHL picture, they used to have a pheochromocytoma also.
Yes, sir.
Nice image and nice picture, nice title. I thought the nodules that hemangioblastoma nodules that you are seeing are looking red. So
Yes.
I thought you said siren because the red light on the top of an ambulance, no?
Yes,
That is what I thought you have called it as a siren. But as you said, rightly said, this is a warning sign for the ophthalmologist, because to whom the patient may present first, and it's our duty to investigate and work up the patient to look for other ominous and more severe life-threatening problems that these patients may have.
Yes,
Very
sir.
nice image and nicely done.
Thank you, sir.
Thank you, sir. So congratulations again, Dr. Surbi. So she wins the certificate and 5,000 rupees. With this, we will move to the February month winners. So coming to the third prize, Dr. Vinit. So Dr. Vinit is a VR fellow in Dr. Girdhar Eye Institute, Kochi. And this is the award-winning image that he has submitted. And this is the description. May I request Dr. Vinit to please describe this image? Multimodal imaging of VKH.
Thank you for the opportunity, sir. Actually, this was a case of a 30-year-old female who presented to our OPD with diminution of vision in the left eye. Her visual acuity in the right eye was 6/6, and in the left eye it was 6/18. So on fundus examination in the left eye, we could find multiple raised elevated lesions around the macular lesion in the left eye, and right eye was okay. So on the basis of fundus examination, we were suspecting a CSR, but when we went ahead and did an OCT, in the OCT of the left eye, there was multiple SRF pockets with a bacillary layer detachment along with thickened choroid. Right eye was normal. So based on the OCT finding, we were now suspecting VKH. So we underwent and further went forward with the FFA and ICGA. In the fundus fluorescence angiography, right eye was almost normal, whereas in the left eye there was mild hyperfluorescence along with early hyper pinpoint which was seen. And in the ICGA, in the both eyes there were hypo patches. So actually, we were diagnosed as a case of unilateral VKH, but we were suspecting it's an early onset VKH, which may be affecting the right eye also.
Yes, I agree with you, Dr. Vineet, because you have mentioned as unilateral VKH, but it may be asymmetrical but sequential bilateral.
Yes,
I
sir,
believe.
sir. Looking at the ICGA, we were suspecting it could be an early onset in the right eye may be affecting.
Definitely the hypofluorescent spots
Yes,
we can
sir.
see there. So we'll take the comments of our expert panel over here. Manisha madam.
Yeah, I think it's a very interesting image, and as Dr. Chitranjan pointed out, that it won't be appropriate to really label it as a unilateral VKH because it is classically defined as a bilateral granulomatous disease, and you can just have increased choroidal thickening in the contralateral eye. That may be the only evidence that it's a bilateral disease, and it as mentioned that it could be just an asymmetrical onset.
Yes, ma'am.
Of a bilateral VKH. So it would be a little too early to just label it as a unilateral VKH, but surely it's a beautiful image.
Yes, sir. Any other comments? Sangeet, sir, your thoughts on this, please.
I think as Manisha has told, and you also mentioned that it's basically a bilateral as the ICG suggests. So it's a VKH. And it is very important to distinguish CSR because as earlier, just by seeing the picture of an OCT, you start diagnosing as CSR and just put the patient on hold and don't treat the patient, the things may get worse. So it's always good to understand that OCT is not the right investigation to diagnose these type of conditions. You should go ahead with a multimodal imaging like he did in this case to find a true diagnosis. I think that is the best solution for these.
Yes, sir. Thank you, sir.
Only differential you have to keep in mind is the posterior scleritis.
Yeah. PMPP sometimes presents like this, but not.
But the septas that you see on OCT are very classical for a
Yes. Yeah, multiloculated is.
Yes, sir. So thank you all panel and congratulations to Dr. Vineet sir. So he wins 2,000 rupees. Probably in the coming AIOS, he is going to give us a treat because it is happening there.
Sure,
correct,
sir.
Dr. Vineet?
Sure, sir. Sure, sir.
Okay, okay.
And
So
I just wanted to commend Dr. Vineet. It's very
Yes, ma'am.
interesting. So very few people have ICG, but you've beautifully shown that even though the other eye looked so quiet, it has so many granulomas that you've picked up on ICG.
Yes, ma'am.
So with this, we'll move to the second winner, Dr. Meghna. So Dr. Meghna is a long-term VR fellow in Joshi Eye Hospital, Hubli. Due to some commitments, she could not join this meeting. And this is the award-winning image what she has submitted. This is worm in the eye. And she has described this is a pseudocolor optos image. Patient vision was 6/6 N6, both eyes. Patient just came to them because of floaters, nothing else. They incidentally diagnosed this. And they just kept under observation, but the patient did not come for follow-up. That's what she has informed me. And this is a very beautiful image, and we can see this is the beauty of optos actually. No financial interest. I'm just telling if we enlarge, still we can get the clarity of the image without much pixelite. I have one question for the panel over here. These kind of images can simulate the uveal cysts or say iris cysts also. So how to differentiate this kind of cysticercosis with a scolex versus the iris cysts? Any of the panel, please.
But she has told that there is what do you call a scolex in this cyst, right?
Yes, sir. She has told.
Yeah, see, two things, Chitranjan. This must be a live cyst because the media is very clear.
Yes, sir.
The live cyst keeps its environment clean. Only
Okay.
the dead cyst will have vitritis. And number two, if you just shine light over this in a live cyst, you can see the beautiful undulating movements on this, which you'll not be seeing with your what do you call the iris cyst, which has gone into the vitreous. So when you shine the light with indirect,
Okay.
you find nice undulating movement of this live what do you call cysticercosis.
Okay. So B scan is not additionally needed in these cases, sir, just to confirm.
No, B scan will show you the scolex, right?
Yes, sir.
So that will be very definitely showing the scolex, but there is no question of observing this case. I think should be operated.
Okay.
I have my own doubts about whether this is really a cysticercosis. I don't think it's possible for this to be cysticercosis because the eye can never be so quiet with such a large live cystic worm in the eye. I think it is some other kind of a cyst, like what you said, pars plana cyst, which has got detached and floating in the eye. I am really surprised that the vitreous is so clear, eye is so quiet, which is impossible in a cysticercosis like.
Sir, but
Only
in a
the other
live
thing
cyst,
is-
it should be very clear. So maybe a dead cyst can lead to vitritis, but if the cyst is alive, I think the environment should be clean. No vitritis noted.
One thing in cysticercosis, generally the cysts are translucent. This it is a
Yeah, the color also is not typical of cysticercosis. That's why I am a little doubtful. I don't know. I mean, since we don't have any more information on the follow-up or any other imaging modality like a B scan or a OCT through the lesion, we don't really know.
Or a live videography also.
Yeah, it actually looks like something arising from a pigmented part of the eye, like a posterior iris cyst
Yes, sir.
or
Yes,
for a pars plana cyst. But I would agree that it doesn't really seem to be like a
Yeah.
cysticercosis cyst.
No, but the description they have said that they have found the scolex in this, probably in B scan or what we don't. But the color, yes, it will be translucent totally.
But how can we see a scolex in this just without any other investigation?
Yeah, probably they might have done, I don't know, maybe a B scan. On what basis they said they found?
If they found a scolex on B scan, they should have given that image also because
Yes,
it is
sir,
so
I agree. So,
typical.
addition of
Yeah.
one B scan image would have been very clarifying in this.
Yeah.
Yes, sir.
Anyway, the person is not there to clarify, so let's move on. I mean, it's very interesting and very rare kind of a picture, definitely.
Yes, but
Very
definitely the picture is very
visually arresting,
Yeah.
And definitely a lot of learning from the panel for all the viewers and for all the doctors. So thank you all for this. And with
If
this,
I had to label this, I would have put it as a shaligrama stone, on the retina or something like that, which is so smooth and black and shining,
Okay. So, so congratulations to Dr. Meghna. So she has won the second prize for this, 3,000 rupees and a certificate. And with this, we go to the first winner, Dr. Bhavani. Pardon, ma'am?
I said we are having some constant enthusiasts for the image competition.
Yes, ma'am. Yes, definitely. These people, Bhavani is a retina consultant in Arvind Hospital, Madurai. And without wasting time, I'll just show the image because after she explains this image, I will announce something else. So, Dr. Bhavani, please explain this award-winning image.
And this was an asymptomatic 25-year-old female patient who presented to us with best corrected visual acuity of 6/6 in both her eyes. She incidentally came for her ocular examination, and the fundus revealed dilated and tortuous arteriovenous malformations in her right eye, and her left eye was absolutely normal. FFA showed no leakage from any of these malformations, and the image was taken using Zeiss Claris. MRI drain showed no vascular malformations. The patient was diagnosed to have Wyburn-Mason syndrome, and she was advised observation and a periodic follow-up.
So
I felt the appearance of the image more like a group of worms. A group of worms is usually called a clue. That's why I gave the title this.
So just to add to it, double congratulations to Dr. Bhavani. This image, the fundus image, I mean to say, this is the FFA image. The fundus image has been published, rather, not only accepted, the May month of Ophthalmology Journal. Ophthalmology, I'm telling, American Journal of AAO, not AJO, American Academy of Ophthalmology, the Ophthalmology Journal, May month cover page. What, like if we Google now, it will come. So as Dr. Manisha Madam was telling, some people are really enthusiastic. So they convert whatever they see in the clinic to kind of award-winning things or publications like that. So congratulations, Dr. Bhavani, again. So she wins the first prize and 5,000 rupees for this. And Dr. Bhavani, please stay with us. March month, third prize. Dr. Bhavani.
It looks like Dr. Bhavani's winning streak is continuing. Congratulations, Bhavani, for winning the best this one for February and the third prize for March.
Yes, sir. That's why, sorry to the panel, I did not take the questions. I can take the questions for Bhavani after this image. For the last Wyburn-Mason syndrome also, and this image also, Medusa head appearance of optic nerve head. Dr. Bhavani, please explain this. After that, we will take questions for both the images.
This patient was a 32-year-old female. She came with the complaints of defective vision in her left eye for a 1-month duration. Her best corrected visual acuity in this eye was 6/18. She was a known diabetic for 4 years duration with uncontrolled glycemic status. Her fundus examination in the left eye revealed extensive fibrovascular proliferation over the optic nerve head. Since the other eye had only a moderate NPDR, FFA was advised, and FFA showed extensive leakage of the dye from the fibrovascular proliferation, giving an appearance of the Medusa head to the optic nerve head. The patient was advised PRP in the left eye.
So, any questions for Dr. Bhavani from the panel, please? Sangeet sir.
Yeah, I think very nice images, both of them. The first one of the racemose type of hemangioma, and the second of the I don't know. It is in the mid-venous phase of FFA, and still those NVD is not leaking that much.
Yes, Dr. Bhavani, you.
Sir?
Dr. Sangeet sir is asking that the new vessels are not that much leaking. The hyperfluorescence is not increasing in the size and intensity kind of thing.
So the late phases showed much more leakage. Since this image showed the Medusa head appearance much more clearly, I took this image for the competitions.
But Bhavani, not much of CNP areas in this.
Yeah.
Okay. Right? Are we missing something in this?
Sir, a few other images which were captured in the periphery had CNP areas, sir, but not many significant CNP areas. A few areas were there in the periphery. Sir.
Yeah, because at least 25% of the retina should be non-perfused to have NVEs or D actually. But here I think the CNP, is it a case of ocular ischemic syndrome otherwise?
Sir, carotid Doppler was done for this patient, sir. It showed no atherosclerosis on the same side, ipsilateral side.
No occlusion? Bhavani, no occlusion?
No occlusion, sir.
Okay.
Yeah, I too had a same doubt because the CNP areas did not look too much. But of course, the periphery, if there are CNP areas, it would still be PDR. And I feel if you had done, have you done OCTA on this? OCTA also can show up these large racemose new vessels quite well, actually, without the need for an FFA also. But of course, FFA would have been needed to confirm the peripheral CNP areas also. Have you done any OCTA on this?
No, sir. OCTA was not done. Since there was an asymmetry in the DR between the two eyes, the FFA was advised for this patient.
I agree. Yes.
Do you have the fundus picture of this patient?
Sorry, sir. I have not got the presentation.
It's okay.
Okay, so definitely lots of knowledge and lots of discussion on this. So I am very much sure that all the viewers are benefited from this presentation. So congratulations to Dr. Bhavani She wins the third prize, a certificate and 2,000 rupees for this image. Then with this, we'll move to the second winner. So as Dr. Saurabh could not make his presence in this meeting, this is the award-winning image we can see over here. He has made the title as double tomato splash. That means it is a combined vein occlusion, both CRVO and CRAO. This is the explanation, this is the description he has sent. A young lady with antiphospholipid antibody syndrome presented with this kind of combined vascular occlusion, and unfortunately over a period of follow-up she developed vitreous hemorrhage with neovascular glaucoma. So the picture looks kind of a painting, but unfortunately the prognosis is grave in these cases, we know. So any comments on this from our panel? With the association of APLA syndrome or any other association etiology we should search for this kind of eyes? Naresh sir, please.
Looks like a combined occlusion, right, Chitra?
Yes, sir. Sir,
Other than APLA, I think another important thing to rule out for combined occlusions is viral infections. So especially in young patients, if you see a combined occlusion, I think that is another etiology to be kept in mind.
Okay.
You're saying something?
No, I'm just telling that the prognosis remains guarded in these cases.
No question of guarded. The patient will definitely go for neovascular glaucoma.
The prognosis is very poor in that.
Yes,
yeah,
sir.
it's a combined occlusion. Therefore, the incidence of NVG is almost universal in these eyes. They don't do well, definitely. And but it's a very dramatic picture, of the eye change what we see, and nicely captured and presented here. Yes.
Okay. Just any role of like, as we all know, according to the CVA study, we don't go for prophylactic PRP or injection. So in these cases, in addition to the systemic management, any ocular treatment we will do in these cases, or just close follow-up only? In the absence of any NV high or anything, any further management we will do in these cases?
I don't think CVO rules will apply for this, but I think we have to go for only close watch. As and when it develops NVG or NVA, we can go for anti-VEGF plus or minus lasers.
Okay. Okay. So congratulations to Dr. Saurabh. He wins a certificate and 3,000 rupees for this image. And the first winner is Dr. Das. The March month first winner is Dr. Deepanjana Das. She is a VR fellow at Dr. Sroff's Charity Eye Hospital, Delhi. And this is the award-winning image. Again, you can appreciate the montage, very beautiful done. The macular eclipse, a case of submacular cysticercosis. So please explain or describe this, Dr. Deepanjana. Is she there, Dr. Deepanjana?
Yeah, I think she is there.
Is there? Please unmute. Yes, Dr. Deepanjana, please tell.
Dr. Deepanjana, we can't hear you.
Dr. Deepanjana, are you there?
Yeah, she's there and she's unmuted also.
Unmuted. Why is she not able to speak?
Okay, Dr. Chitranjan, maybe we can read out the description of this image.
Yes, ma'am, you want to make any comments? I think
Yeah, so
you
I
have
can just,
managed.
I actually operated this case, and a young male patient, and he presented with a diminution of vision in this eye. And it was indeed a dancing delight, because even when we were trying to, or when we operated to take out the cyst, it kept dancing. And basically, we did a submacular detachment of the retina, and we got the cyst out in toto. And of course, this was followed by an MRI of the brain to rule out any evidence of neurocysticercosis. The patient is doing well. He did have an evidence of neurocysticercosis. So he was subsequently treated with antihelminthics and oral corticosteroids. Dipanjana, would you like to add?
Extremely sorry, ma'am. Am I audible?
Yes,
Yes.
yes.
Please go ahead.
This is a patient of. This patient came to us our OPD with complaining of diminution of vision left eye. At presentation, his visual acuity in the right eye was 6.6 and left eye was 6.60. On exam, dilated funda with the anter-segment examination was unremarkable, and the ocular motility was full in all direction. On dilated fundus examination, the right eye was normal and the left eye showed a yellowish white dome-shaped elevated lesion involving the macula, and with a whitish yellow lesion in the center, which is a suggestive of a scolex, and another yellowish white area in the superior temporal to the large lesion, which is suggestive of the probable site of entry. We also did a B-scan ultrasonography to confirm the disease, which shows a cystic lesion with a high reflective clump echoes within it. So it was suggestive of intraocular cysticercosis. The patient, as ma'am already told, that the patient was operated with removal of the scolex and under steroid cover also, and he had a good visual visual acuity of 612 in this eye.
Okay, great. So again, these kind of images, as Madam has told, to search for cysticercosis elsewhere like CNS and to start antihelminthic drugs, all these things point towards kind of having a suspicion towards diseases in other parts of the body as well. So thank you, Dr. Deepanjana, and nice image. So congratulations, she has won the first prize and she gets the certificate for this and 5,000 rupees for this image. With this,
Chitran, just a point.
yes, sir. Yes,
You have to treat with antihelminthic for a long time in these cases.
yes, sir.
Another point, like what they had done very nicely, that they removed the cyst in the eye and then started antihelminthics. So if you start antihelminthics before removing, then this may become a dead cyst and cause a lot of inflammation inside the eye.
I think that's a very important point, that you just have to start them on oral steroids initially and operate them. And after you've removed the cyst, only then start the antihelminth.
Okay, okay. So all great points. So with this, we come to the end of the presentation of the winners for VRSI image competition for the months of January, February, and March 2023. May I request Dr. Sangeet sir to please say a few words of encouragement for all the young doctors.
Thank you, Chitranjan. I think we are now getting very good images. Initially, we were very disappointed because the image quality was not that good as we thought so. But nowadays, now the people are posting good images. And I'll just to the young ophthalmologists who are listening, who are taking these photographs, I would just say that the only competition for you is with yourself to post that first image. Because what you think is not good may turn out to be extraordinary for the viewers and may even come up trumps in this competition. So just keep posting. I think that is the main thing that I would like to say to everybody who is listening. Just keep on posting pictures, and anything may turn out to be gold. Thank you.
Yes, sir. Thank you, sir. So with this, over to Manisha Madam.
Thank you, Dr. Chitranjan, for making all the effort for making this image competition a grand success. And the kind of entries and images that we get every month speaks volumes of the kind of level this competition has reached. And I'm just looking forward to more new people giving their entries. We have some marathon runners now in this particular competition. So I would be happy to see some new names now come up as winners. And just a very warm thanks to the entire team. You people are doing a great job. And I look forward to the best image of the year.
Yes. Any other comments from the panel, or we'll close the presentation? Okay, if there are no more comments, thank you all the presenters and all the viewers, all our expert panel. A great learning for all of us. Again, with the message to all the doctors that please keep submitting all your beautiful poster segment images. With this, we conclude this presentation. Thank you, one and all.
Thank you. Good night, Chitranjan. Good night.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you, Chitranjan.